Okay. So, I'm Dr. Megha Agrawal from Healthcare Sector Skill Council. I'm extremely thankful to all of you to join in on our 8th Healthcare Insight series, the 8th webinar under our initiative Healthcare Insight series, which we regularly conduct in association with the industry partners to give you insights and valuable inputs for your clinical practices and other value chain of healthcare industry. This time we are holding it for the clinical dietetics, and we have the panelist from Kaho Clinical Dietetics Forum, moderated by Ms. Sangamitra Chakravarti, with some other panelists from esteemed institutes, and also as a co-chair of Kaho Clinical Dietetics Forum. So now it is over to Dr. Ms. Sangamitra Chakravarti, ma'am, to moderate the session with all the panelists. Thank you.
Thank you so much. I hope I am audible. Am I audible?
Yes, you are audible.
Okay.
Yes, ma'am.
A very good afternoon to all of you and welcome for joining us today. At the outset, I would like to first thank HSSC and Kaho for allowing us to speak today on the science of clinical dietetics. We basically are a vertical directly under the Kaho leadership, the Clinical Dietetics Forum. And the purpose of this forum is to promote quality in clinical dietetics in India. We are trying to do it pan-India, and that is why we have got representation from all corners of the country. And today you find that the co-chairs are from north, south, east, and west. So the purpose of the talk today is to enlighten people on the science behind the subject of clinical dietetics. Many of the people who have joined us are probably in the same field as us, dietitians or budding dietitians, students, nutritionists, or maybe other healthcare practitioners. But you all would agree that there is still a lot of confusion in our country regarding who actually a dietitian is, whether she's a skilled professional or not, what exactly she is expected to do. Usually, people, when they are overweight, they always associate themselves with dietetics and they come to the dietitian and tell them, please give us a diet chart to lose weight. But it goes beyond that. We are healthcare practitioners who are not just responsible for making people lose weight, but also we are actively involved in different healthcare scenarios, in clinical research, in counseling, and dealing with a variety of disorders. So in order to enlighten you on the science behind our subject of clinical dietetics, I have 4 panelists here today. And I would like to start with Miss Susan Itti, who is the Chief Dietitian of Aster MedCity from Kochi. She will be talking to you about the grooming of a dietitian or the making of a dietitian. What exactly goes into making a clinical dietitian? What are the prerequisites? What are the things that one needs to study? How do you train yourself? Is it just studying in college, coming out and working, or do you actually need proper extensive training? So what are the skills that are required for a clinical dietitian to practice? What are the challenges? Miss Susan Itti will be enlightening you on this. Susan, I welcome you to please take the stage.
Thank you, ma'am. Thank you for the introduction. Thank you for the introduction. Yeah, thank you. So today I'm going to discuss about what are the qualification a dietitian needs and training, what are the environment and how you can become a clinical dietitian. So next slide, please. So in our country, dietitian means everyone knows only one thing, that what Sangamitra ma'am has said is like how to lose weight. If you want to go, you can go to a dietitian. It's not like that. There are different category of dietitians, and whoever wants to work in a clinic is a clinical dietitian, and whoever is working inside a food industry or in the hospital kitchen or a community kitchen, you can call them as a food service dietitian. And some other category is community dietitian. that is the dietitians who works in a community for the development of the community, or you can see many people associated with the pregnant women and senior citizens, all those things. So they are the community dietitians. So actually a clinical dietitian is only interact with the patients, and patient care she will take care of, and she is a part of a multidisciplinary team, and she takes parts rounds with the doctors and the nurses. She will be coordinating with the nurses, and she will be doing the assessment of the patient. Then only she will recommend a diet for the patient. So details of that will be following in the other slides. And but in food service dietitian, that there is no part in uh, clinical dietitian doing in the food service area. That means in hospital, food service area is taken care by food service dietitian. Can you put the previous slide? Uh, by the food service dietitian, she will be, no, previous slide, the first slide. Yeah, this slide. So she will take care of the, when the clinical dietitian gives the order for, suppose if it is a diabetic diet or a renal diet or whatever, the food service dietitian has to plan for the recipes and menus according to the prescription given by the clinical dietitian, and she will be in coordination with the chef and food service people, and she will serve the food for the inpatients. And the community dietitian, as I explained earlier, she will be trained in developing programs and promote health food choices to specific groups like pregnant ladies, lactating women, and senior citizens, all those things. So this is the difference between a clinical dietitian, a food service dietitian, and a community dietitian. Not one, this clinical dietitian cannot do anything in the community, and the community dietitian cannot do anything in the clinical part. So the whatever they are studying is totally different. And clinical, so next slide please. The qualification. So I am today going through only about the clinical dietitian. So the qualification needed for a clinical dietitian is to, or to eligible, whoever is eligible to work in the hospital should have graduate in food and nutrition, food nutrition and dietetics, or clinical nutrition, or a graduate in BSc Home Science with the food and nutrition as specialization. The student should have covered minimum of 4 courses of the following, like nutrition and biochemistry, food microbiology, basic nutrition, clinical nutrition, and therapeutic nutrition, or the graduate degree with a minimum of 4 nutrition related subjects like basic nutrition, biochemistry, human physiology, diet therapy, clinical nutrition, diet in diseases. And she should or he should be postgraduate degree in food and nutrition, or clinical nutrition and dietetics, or in some hospitals, uh, postgraduate diploma in food and nutrition also will be considered when these MSCs or postgraduates are not available areas. Next slide, please. And the training after the MSc, they should undergo a 6 months of continuous internship from hospitals recognize in accordance with the competency standard package after the post graduation. So a 6 months of internship should be done after their course, and sometimes they can do certification in specialized subject like pediatric dietitian, renal dietitian, diabetic educator, all those things also they can specialize. But before specialization, they should finish their 6 months of internship in the recognized hospitals. And for training, they can attend many conferences, webinars, trainings, etc. is available according to many bodies. They will arrange all those things, so they can uh, uh, get the training from there also. But a continuous nutrition education should be there to update their knowledge, and for to know about the guidelines and all those things. They should have a training, continuous training sessions should be there. Next, please. And licensing and membership in India, actually, there is no particular licensing for dietitian, but as we are all into Kahu, we all are uh, planning for making some license for a dietitian. Whoever wants to works in a hospital. Before we were having registered dietitian, RD was there. So whoever after passing the MSc, they will be undergoing a 6 months internship under a uh, under a registered clinical dietitian, and they can go for the exam. Or after 5 years of experience, they can write the RD exam and pass the examination. And the dietitians can have membership in IDA, Indian Dietetic Association. IAPN is the Indian Parenteral and Enteral Nutrition Association for Parenteral and Indian Enteral Nutrition. AIDEN is a Association of Evidence-Based Dietetics and Nutrition, that is now only in Cochin. And NSI is Nutrition Society of India. All those are the membership given to the dietitian. This IDA is only for dietitians, but IAPN doctors are all paramedics are involved in that. AIDEN also is only for the practicing dietitians. NSI, anybody can join, like a dietitian or the professors, or anybody can join in NSI also. Next slide, please. And the duties, the clinical dietitian main duties in the hospital is nutrition planning and achieving the goal. After the assessment of the patient, the clinical dietitian will be fixing a nutrition goal for the patient. There, to achieve the goal, they have to plan according to the patient condition, all those things. So her main duty is to achieve the goal for the nutrition goal. And nutrition care process is there, that are assessment, reassessment, all those things are the nutrition care process. And coordination with the F&B or the food service dietitian to achieve the goal, and coordinate with the medical departments, operations and management for the for the improvement of the patient. Next slide, please. And this is how the organon of a dietitian or nutrition department. The chief dietitian will be the dietitian will be under a medical superintendent. Then under her, the senior clinical dietitian and the clinical dietitians will be coming. But if it is a food service dietitian, they will be reporting to the operations, and under them their dietitians or F&B manager or anybody can come down. Next slide, please. Thank you. This is how, this is just a glimpse of everything, the qualification and everything. If you want further any doubt or anything, I can clear it now.
I think all of you have gathered that basic information about what goes into making a clinical dietitian. You have to have a very sound background of biochemistry, physiology, and the basic sciences. Otherwise, you will not have, if you do not have a proper foundation, it is very, very difficult to practice because your fundamentals come from what you learn in college. But when you go out into the hospital, when you start practicing, you have to know how to apply those into the real world. So for that, the training is a must. And also, you need to develop certain special skills to be able to talk to the patients, to be able to talk to your co-workers, and then only can you properly become a clinical dietitian and call yourself a proper professional. Now, before we proceed to the next speaker, Susan, can I just ask you a question?
Yeah, ma'am.
Please mute yourself.
Ma'am, I can't hear you properly.
1 minute. Please mute yourself. Yeah. Can you hear me now?
Yeah, somehow. Yeah, tell me, ma'am.
So, Susan, can you just explain to everybody why the clinical training is so important? Because nowadays, the tendency is that many students, they go for online training after their degrees. Do you think that they acquire the same amount of skill if they do an online training, or do you insist that it should be absolutely hands-on training in a multi-speciality hospital?
Yeah,
Please.
ma'am. Yeah. So, the practical knowledge one should gain only once you see the patient only. Online, if you see a patient, you cannot assess a patient. When we are going to assess the patient, we have to see the patient, we have to talk to the patient. And without talking to the patient, you cannot do a nutrition assessment for a patient. Before planning any diet or anything to a patient, we have to assess the patient in detail. So without assessment, you cannot fix a goal for the patient. For assessment, you need a good training from a trained dietitian, because assessment is not just like asking some questions and coming back. It is now the NCP has come, so real assessment, touching and assessing the patient, all those things are very, very important now. So with and reassessment, just the assessment is not enough. So after introducing or after doing the intervention, we need to reassess the patient. For reassess the patient also, you have to see the patient. If you are sitting somewhere and doing something in the system, that won't help you. We have to see the patient, and then only we can understand the situation, how the patient is. If if there is suppose if the patient is having any edema or ascites, through the online you cannot learn anything what is ascites or what is edema. You have to see it with your own eyes and assess the patient. You have to touch and see, then only you can understand what is that. Without that, you cannot make a goal for the or plan a diet for the patient. And as well as when you talk to the patient, you can understand what is the issue the patient is facing. Like sometimes some particular food, if the patient is eating, he cannot tolerate that, or he may be having some difficulty in that. So when you see the patient, when you talk to the patient only, you can understand all those things. So if you are getting a training from a trained dietitian for at least 6 months, you can see how they are getting the information or how they are doing the assessment by to a patient, and then how they are doing the planning. If we are not assessing or we are talking to the patient and doing the nutrition plan and all, you cannot achieve the aim what you are, or you cannot achieve the goal what you are aiming at, or the patient will not be comfortable enough to follow that, because when the patient is having some issues with the food what we are prescribed or suggested. So to get the correct information about the patient, you should see and assess the patient, not through the this one. And when you see the patient or when you go through the case sheet and when you discuss with the doctor, then only you can understand what is the real issue the patient is facing. So if you do it online, you are not getting anything from that. You are just writing some like a assignment or some case study, whatever information is available in the system. Nothing you are getting from the patient or from the doctors or from the nursing staff. Even from the nurses also you will get some idea about the patient. So with all these things only you can make a plan of the patient. So it is very very important to have a training inside the hospital, not from the online or sitting somewhere and getting. That is not at all feasible. And if you are not getting the training properly, you cannot help the patient in the future. So if you are not helping, if you cannot help the patient, please don't harm the patient. Because if our parents are there, we cannot suppose our parents are lying down and somebody sitting somewhere and giving the diet, that will not help us or help our patients. So when, as a dietitian, we should think that the patients are like our parents or our sister or brother or whatever. So that empathy, sympathy and all should be there. That you can achieve only when you see a patient. The other things are mechanically we are doing, that will not help you at all. Is that okay, ma'am? This much is clear?
So, if all of you have listened carefully, Susan has dropped a very, very important point that we cannot harm the patients. We have to treat them like our own family. So it is very, very important for any budding dietitian, any aspiring dietitian to groom herself or train herself very well, because she cannot afford to make mistakes at practice. And that is only possible if you have a very strong fundamental, if you are well trained and you're sure about yourself. So when you are trying to become a dietitian, do not take it casually. Take it up as a serious profession and work towards it, and make sure you have a strong background before you apply for a job. Thank you, Susan. I think we can take more questions later on. We can now go to the next speaker. Our next speaker is Dr. Divya Chaudhary from Rajiv Gandhi Cancer Institute, Delhi. Dr. Divya will be speaking to you about the role of a dietitian in the hospital. Now, you've heard about what makes a dietitian, but what when the dietitian has actually joined work? What is the kind of work that she should be doing? We find that if we look backwards, earlier the dietitians were mainly confined to hospital kitchens. And the only work that they did was raising tenders and meeting patients and taking food orders from them. But that is not the definition of a clinical dietitian. She has a long way to go. And her job, her role, what exactly it should be like, what is her role as a healthcare provider, that is going to be made clear by Dr. Divya Chaudhary. She will explain to you how a dietitian works as a member of the multidisciplinary hospital team. So I invite Dr. Divya Chaudhary to please speak and enlighten everyone on the role of a dietitian in the hospital. Welcome, Divya.
Thank you so much, ma'am. Once again, good afternoon to all of you. as my earlier colleague, am I audible? So, as my earlier colleague has already explained that what are the prerequisites for becoming a dietitian and things like that, today I will try and sail you through that what is the role of a dietitian in a hospital, how does a typical day looks like, what all are the functions she needs to take care of, what are the responsibilities of a dietitian while working in a hospital setup. So generally, if we, think from a layman's perspective, suppose if someone is going to a hospital for getting a treatment done, so the first thing which comes to their mind is that, we'll speak to a dietitian about what we can have. We will order her things that get us prepared these things. We want to have food choices. We want to have foods which we like and things like that. So this is a general notion the general public carries. But this is just the tip of the iceberg. A dietitian has to play far more responsibilities. A dietitian has to play far more than this basic notion the general public carries. So let's quickly move on to that. How the dietitian starts a day in a hospital. There are different floor sheets or ward sheets which are called different in different hospitals. Based on that, the dietitian goes to the ward, ICUs, or any critical areas. If it's a oncology hospital, it can be a bone marrow transplant unit. In multi super specialty hospitals, there could be a kidney transplant unit or a liver transplant unit, a pediatric unit. So whatever wards and ICUs, critical and non-critical areas we have, a dietitian will go to all the wards and ICUs and meet each and every patient. So the purpose of meeting every patient is not just discussing about what will they have, dal roti, khichdi, or sprouts or something like that throughout the day. There is a purpose for meeting a patient. Once we meet a patient, we have to gauge what cultural background the patient is coming from, what are his likings and dislikings. Then we read the files. A dietitian is supposed to read the files, what the doctor has written, what the notes are therein. Then she will have to go through the biochemical parameters like hemoglobin or calcium or KFT, LFT, kidney test, liver function test, whatever depends on the patient's profile. Then during the meeting, the dietitian has to explain to the patient that yes, you are on normal diet or soft diet, whatever the diet has been prescribed by the doctor. These are the things which you need to restrict. These are the things which you need to include in your diet. So this is like a counseling. Counseling does not mean that at the time of discharge, the dietitian hands over just a diet chart that this is what all you need to do once you go back home. So counseling happens on a regular basis. On a routine basis, once you meet the patient, you have to guide the patient regarding the diet choices during the stay of the hospital also. Then the dietitian has to meet or speak to the doctor if required, depending on the case of the patient. She is supposed to document everything. See, it's not just that her role finishes, that she has taken the round, met the patient, give the kitchen instructions for what has to be given to the patient. It is equally important to document also what she has seen or observed during her rounds. A patient could be malnourished, a patient could be losing weight, a patient is not able to catch up with the daily caloric and protein requirements. So once, like Susan said earlier, nutritional assessment is important. So these are components of nutritional assessment. You see the patient, then you document this. Documentation is also important because only after documenting, the doctor will read whatever a dietitian has mentioned in the file, and he or she will come to an understanding. Yes, the dietitian has made a note that whatever were her observations and what was the recommendation from the dietitian's side. So these all things go into her perspective, into her kitty. Once the dietitian is through with the rounds, then she will come back to her desk. There might be few cases where she will have to monitor special cooking because there are different clinical conditions to be taken care of. Then, depending on hospital to hospital, there are different ways of diet planning. In most of the hospitals in big cities
सोया है
like
बेटा वो
Bombay, Bangalore, Hyderabad, Delhi, now we have come up with softwares where we are putting in all the entire day's diet planning, that what all has to be served to a patient, because most of the hospitals are NABH accredited and they have protocols to follow, that every instruction has to be written, then only given to the FNB personnel so that they can read and the chances of error is minimum. So depending on the hospital type, somewhere the manual instructions are given, somewhere we just put the instructions in the software. So the crux is that written instructions have to be given to the FNB purpose for service of the individual patients. So whatever number of services a hospital is providing, right from the morning tea till the day finishes, everything has to be written, passed on to the service people, so that the chances of serving a wrong diet is minimalized. So it is a huge task. It's not just कि बस खाना खिलाना है. No, it's not like that. It's much more than that. And a lot of time, lot of energy, effort goes into the diet planning, because every meal you have to plan, every ingredient, every kind of dal or fruit or vegetable, you have to think that this patient is on a renal diet. Again, I'll say कि खाना ही खिलाना है. That's how dietitians are perceived, and together with Kaho, I am sure that we'll be able to change this notion and move forward in our constant efforts. So this is a small cycle where nutrition assessment first is done by the dietitian. Even before the nutrition assessment, nutrition screening has to be done. In nutrition screening, you come to know various tools are available. MUST is a very common screening tool, MUST. After screening, you tend to come to know that who all patients are at risk of malnutrition and who all are not. So patients who are at risk of developing some form of malnourishment, you go further with the nutritional assessment. There are standard tools which are available. There is Nutri-Score, there is SGPGA, many others you can use, or you can even customize as per your requirement. Then, depending on the nutritional assessment, you come to a nutritional diagnosis. Then you start planning with your nutritional intervention. What kind of a diet needs to be planned? After that, nutrition monitoring and evaluation is equally important, because if we do not evaluate or monitor, the earlier 4 steps will go down waste. So monitoring or evaluation is an important step to complete this entire cycle. Next slide, please. So our dietitian does not work alone. She has to work in tandem with lot of stakeholders so that every meal tray which is served to the patient, it goes right. There are a lot of stakeholders with which a dietitian has to interact on a daily basis. The first and the primary most is the doctor. Definitely, yes, we have to discuss with the doctor if at all it's a surgery case, what kind of a surgery, and very minute details, so that we are able to come to a nutritional diagnosis also, and then start planning the nutritional intervention. Then we have to be in regular touch with the patient and even the attendants, so that they are also in sync with what we have guided the patient, what is good for them, what is not. Education and awareness of the attendant is also equally important. Then comes the nurse. There are many things which you will be writing and documenting in the patient's file. But those instructions should be carried forward. For that, nurse is equally important. And the communication with the nurse should be there on a regular basis, because dietitian is not there in contact with the patient for 24 hours of the day, but the nurse is. Suppose we have to do a calorie count of a patient who's not been eating well. So we'll tell the nurse to help the to note down how much quantity of the food patient has eaten, so that next day when we come, we can do the calorie and protein calculations. Then next comes the food and beverage staff, the food and beverage managers, the supervisors, then the stewards who go and serve to the patients. You have to train them on a regular basis. They should not be doing service errors. They should be well versed with the hospital, how to pack the food trays. So these are certain points which where I strongly believe that the dietitian should be dealing with them on a regular basis on training of these points. Then comes the quality manager. A quality manager is also equally important. We have to lay down our SOPs, the protocols, how will the department be functioning. So the role of quality manager comes in. Now, Kaho is a quality platform. So that's how quality is important. And without a quality manager or a quality officer, the dietitian's work will not be 100% complete. Because if we are serving a patient, if our quality goal and whatever benchmarks we decide for ourselves, we all must be having different quality parameters in our hospitals to follow. The quality manager will be constantly in touch to evaluate. Like I discussed in the previous slide, that evaluation is an important part. So quality manager also helps us in evaluating our performances. Then the pharmacist has their own role to play. Most of us, we generally recommend nutrition supplements to our patients. Now, we need to be in regular touch with pharmacists, what all nutritional supplements are coming, any latest updates, any ingredient or something like that. So we should be regularly in touch with the pharmacist to keep this point in concern. Then, in special cases like dysphagia or CVA, stroke, or other certain conditions, the role of physiotherapist, speech therapist, or deglutition therapist also becomes important. I'll just explain this with the help of an example. Suppose I'm dealing with a patient who has dysphagia. So then with the help of a speech therapist or a deglutition therapist, I'll be able to come to know what is the swallowing power of a patient. By this, I will be able to decide with the consistency of the food which is comfortable for the patient. So the dietitian has to be in touch with so many people so that a patient can recover from the illness, the quality of life of the patient improves. I'm sure we are all working with this goal with our patients, that we have to help the patients improve their quality of life. Then a very important stakeholder is the IT department. Like I said, most of the hospitals have developed dietary softwares. Like in my hospital, I have developed a proper software wherein it starts with the nurse putting in the diet order, the order taker acknowledging it. That's a process. So we can have our own processes in our own respective hospitals. Depending on our requirements, the requirements can be different from hospital to hospital. So IT, again, with artificial intelligence coming in and all these technological developments, the role of IT has also become very important. Last but not the least, this is a very new stakeholder, I would say, that NGOs and the role of philanthropist. How? In my I am working in a oncology setup. So in my setup, there are a lot of people which come from a very, I would say, financially weak background. And the kind of patients I cater to, the requirement of calories and proteins are really on the higher side. And in that case, we have to prescribe them nutritional supplements. Now, most of the patients who belong to the financially weaker sections, they are not able to afford these nutritional supplements. As a result, they are not able to recover in the selected time frame. So, if NGOs or philanthropists or certain organizations or corporates tend to pitch in, they donate some nutritional supplements or find some way out in which where we can help these patients, because healthcare is for all. We cannot ignore a patient just because he or she is financially weak. If we are working as a healthcare professional, it becomes a moral responsibility also to make health easily accessible to one and all, whatever efforts we can do that. So I personally think that yes, the role of NGOs and philanthropists is also important like this, so that we are able to cater to the demands of or the nutritional requirements of such people. Next slide, please. Next slide. Can you please shift the next slide? Okay. So, being a dietitian is not easy. People generally perceive that the dietitian just comes to the hospital and gives the food to the patient. So today I'm sure that I was able to explain that the role of a dietitian is multidisciplinary. And without food and nutrition intervention, no treatment can be complete. That's the humongous responsibility on a dietitian's shoulder. What a general person sees is just the tip of the iceberg. And apart from all these things which I just shared with you, discussed with you, it is also the responsibility of the dietitian to formulate training programs for all these stakeholders, like the kitchen staff, nursing staff, because they are serving the patients, they are administering nutritional supplements to the patients, giving tube feeds and different forms of therapeutic diets. Interns come to us after the college. The college will prepare them with theoretical knowledge. What and how to apply in practice, the hospital helps to teach them, to groom them, so that they are ready to deal with patients. So again, it's our responsibility. Then regular training programs for attendance should also be there, because attendance and patients are just not there in the IPTs, they are in OPDs also. It is our responsibility and duty to connect with doctors, to connect with peers, so that we are able to exchange information, share our viewpoints, and learn also from them. So, being a dietitian is not easy. She has a very big responsibility in the patient's journey called health. So, this was from my side today evening. Thank you so much for a patient listening.
Thank you, Divya. That was wonderful. I'm sure everyone has understood things that you have explained so beautifully. So, what Divya was trying to say is that we are not actually food order takers. Dietitians are not really food order takers who just go around from patient to patient taking food orders. Rather, they are nutrition therapists. So, in order to be a nutrition therapist, you have to have a very structured outlook, and the way in which we work, it is basically based on evidence-based scientific practices. So today, if Divya thinks that she wants to screen the patient in a way, I think it's a different method that I want to use. And Susan thinks, no, she wants to use a different way. It doesn't work. We have certain tools, certain guidelines which actually tell us how to do it. So it's a very structured thing that we all need to follow. And all this is based upon proper scientific research and endorsed by scientific organizations. So just like the doctors have certain protocols to follow, if you are a trained clinical dietitian, you need to learn all these protocols. And these are not taught in colleges. You need to do this hands-on, learn all this hands-on at a proper reputed hospital under a trained dietitian. And also it is very, very important for us to work in a team, as Divya explained. We are a part of an extensive team and we need to work in the team and not in isolation if we have to give proper patient care. Thank you so much, Divya. If there are any questions, I think we can take it later. Now we would like to go to the next talk. Now, I would like to ask you all a question. What is your concept of a dietitian in society? How many actually think that a dietitian is important in society? The answer will be usually no, they are not required. As it is in hospitals, when we tell patients, do not eat this, do not eat that, we become unpopular. So a person in society who is not hospitalized, who is apparently healthy, if we go and tell them that, okay, we are clinical dietitians, we have come to give you some advice on nutrition, we will definitely not be very popular. Because the person outside the hospital may not be really sick. He may not have a fever, he may not be having some pain or some infection, so he thinks he is healthy. But in reality, he may be suffering from some non-communicable disease, which we know are silent killers today. Hypertension, diabetes, gout, metabolic syndrome. Apparently, you do not have any problems with all these things in the initial stages, but they, in the long run, land you up in hospital. So there comes the importance of a clinical dietitian in society, in the OPD, the outdoor patient department. You need not be hospitalized to seek the advice of a clinical dietitian. It can be done outside the hospital. So for the people in the community who need help from a trained dietitian to talk to them about the problems of the non-communicable diseases, how to lead a healthy lifestyle, to talk about wellness. You need a proper trained clinical dietitian in the correct OPD settings who will guide you and counsel you properly. This counseling is very, very important because that is what differentiates a clinical dietitian from any other personal. Also, people who are discharged from the hospital, very often we have no idea what they do once they go home. A discharge summary is given, probably a diet chart is given. But what happens to these patients in the long run? Nutrition therapy does not end in the hospital, especially for chronically ill patients like cancer patients. It has to be done outside the hospital in the form of a rehabilitation. Otherwise, what we find that these patients are again readmitted, or the quality of life of these patients, it really goes down. So in order to talk about nutrition rehabilitation and the role of a dietitian in the outdoor patient department, we have a very experienced dietitian from Coimbatore, Miss Kavita. She's from PSG Hospital. She's going to tell you about the importance of diet counseling, how a dietitian is important outside the hospital or in the hospital OPD, and how she can actually help in, not just rehabilitating patients, but also playing a very crucial role in preventive healthcare. Kavita, I request you to please take the stage.
Good afternoon. You're able to hear me, ma'am?
Yeah, we can hear you.
So as Madam Divya and Madam Susan had updated on the role of the dietitian, clinical dietitian in a hospital, we also have an additional role as an outpatient dietitian. Like most of the hospitals, they have an outpatient department, and a dietitian is assigned there to take care of the outpatients. So a referral to a dietitian in the outpatient department is an essential process, not only for the patients who are coming to the hospital, but also for any person. They can just walk in and seek an advice from a dietitian in the OPD. So a referral can be from a physician, a nurse, or any other healthcare providers, or it can be a self. Anybody can just walk in and ask for a nutritional. They can just talk to a dietitian and find what they want for themselves. So this is just a specialized nutritional care which is tailored based on the medical conditions, and also if they are healthy, also they can have a well balanced diet, talking to a dietitian in the OPD. Next slide, please. So who can walk into an OPD to meet a dietitian? It can be referrals, as I said, from the healthcare professionals for treating them who have problems with diabetes, mellitus, hypertension, cardiovascular diseases, or any renal diseases, or they have some gastrointestinal problems like IBS or celiac disease, Crohn's. See, all these chronic diseases have to be taken care of, and nutrition plays a major role in treatment of these diseases. So meeting the dietitian regularly will help them to control these conditions. And apart from that, if there is any nutritional deficiencies that the doctors come across, they can refer their patients to the OPD. For example, small children, they have iron deficiency, anemia, and elders will come up with calcium deficiency or vitamin D deficiency. So these patients can be referred, and many of us see patients with overweight or obesity problems. So for weight management also, they are referred to a dietitian, and some of them come to a doctor to check that there is some weight loss, unexplained weight loss or unintentional weight loss. In those cases also, we'll have to find out the reason behind the weight loss and try to correct them. And apart from that, those who are planning for pregnancy or those who are pregnant for gestational diabetes or preeclampsia, they are referred to a dietitian. And even the lactating mothers, many of them do not know what to provide, what to eat for themselves, and is it necessary to breastfeed the children. So all these can be explained to them, and I think the clinical dietitian in the OPD will be the right person to guide them from pregnancy through lactation. And failure to thrive or growth concerns are also seen in pediatric population, or patients with food allergies or intolerances are also referred. And certain patients who have undergone surgery, either for oncology patients or any other GI surgery patients, pre and post surgical nutrition support plays a major role in case they are undernourished. So they are also referred. Enteral or parental nutrition planning plays a major role in this population. And there are few patients with food allergies and intolerances. So detailing about what foods to eat, what foods to avoid plays a major role in decreasing their symptoms. And lifestyle related issues in case of dietary modifications for metabolic syndrome, or there are few vegetarians or vegans or specific with dietary preferences. So they also approach a dietitian in the OPD for detailed diet planning and suggestions as to how to plan their menus in their routine. Next slide, please. So an outpatient department dietitian plays a pivotal role in managing and improving the nutritional health of patients in clinical or hospital setting. So the key responsibilities that you have to do as a OPD dietitian is, first thing, to do a nutritional assessment. So as soon as you receive a patient, a referral from a healthcare profession or a person who is walking into you, you need to do a detailed nutritional assessment with validated tools. We have several screening and assessment tools available, which is validated by different societies. So you can use any one of the nutritional assessment tools in your OPD to do the detailed assessment. Then based on the assessment, you can do a dietary counseling. And in case there are having some chronic ailments or chronic diseases, then you'll have to do a detailed management of those problems. And you can also have patients with preventive care. I don't want to become sick, or I have to be fit. There are a few patients who will walk in and ask, how can I be healthy? How can I have a nutritious diet to stay healthy? So preventive care also you can provide. And monitoring and follow-up is very important. collaboration with healthcare teams, specialized diet planning, and research and continuing education. We'll see them in detail in the next slides. Next slide, please. Next, yeah. So the nutritional assessment, as I said already, we have to use a validated nutrition screening or assessment tool so that you can collect the details, as Divya ma'am was insisting on, to collect the complete history of their dietary pattern. And in case they have some medical problems, if they have their records with them, medical records with them, you'll have to go through that. And the biochemical parameters. And apart from that, you will also have to note down certain details like their routine from morning to night. What do they do? When do they sleep? When do they eat? And who does the cooking? And all these things also have to be recorded. And with this, you will have to identify the nutritional deficiencies in these persons. And in case they are undernourished or overnourished, you will have to record that. And after that, you will have to do a detailed counseling. So you will be doing education. You will have to modify their eating habits and lifestyle based on the condition of the person. You will have to educate the patients with their routine. So just like that, you cannot tell eat that, eat this, or you have to do this, do that. No, you have to sit with them and check whether it is feasible for them, because each one of them will be working somewhere, or they will have their own lifestyle, or they will have their own routine. So you will have to modify the dietary pattern, or certain habits have to be changed based on their routine. So if you tell them what they have not been doing, it is difficult for them to follow. So you will have to consider their preferences, dietary preferences, and also cultural practices that they do, and also their socio-economic status. So based on all these conditions, you will have to provide them with a detailed dietary plan, as well as how to prepare those food items and how they can alternate if one is not available, how to alternate it. Based on these preferences, you will have to provide them a dietary counseling to them. And there are certain conditions like chronic or acute medical conditions like renal diseases or cardiovascular or gastrointestinal problems. So based on their signs and symptoms, sometimes certain food items will be allergic to them. So you'll have to find out only when you do a detailed assessment, collecting the dietary history, you will be able to identify their intolerances and try to provide them with an alternative food. So you will have to design a therapeutic diet which will suit that particular person, so that there is improvement in the symptoms, and they have, for example, if it's a IBS, there should be a decrease in the symptoms. So unless you find out the food that is causing them problem and telling them to avoid it, it is not going to help them. And apart from that, there are certain conditions like oncology patients undergoing a surgery, or any GI surgeries, or any other cardiac surgeries. So pre and post-op nutrition is very important. So it is not sufficient that you provide them with adequate nutrition when they are hospitalized. So when they go home also, you will have to continue the same nutrition support. And when they come for their review, maybe the doctors will tell them to come for a review after a week or after 10 days. So when they come back for a review, when they meet the doctors, you please tell them to meet you also. So they can come to an OPD with all their details as what they have been eating after their discharge, post-discharge, what is their nutritional intake, and did they find anything difficult in following the diet that was prescribed here, and make necessary changes so that you will be able to maintain their nutritional status even post-discharge. That is also very important. And preventive care, anybody can walk in to you and ask for a diet that will help them to stay healthy, whether it's a normal person with no problems, no medical problems, an adult, or for his or her children, they might ask for a healthy eating. What is the healthy eating pattern that can help them to prevent certain diseases? So we can also have conduct small workshop or group sessions on these preventive nutrition topics inside the hospital, or you can also go in and do these sessions in a school, or you can create awareness in a workplace, any IT companies or any other workplace, so that you can help them to prevent these metabolic diseases. Next slide. Yes. So monitoring and follow-up is another key responsibility, where you have to tell the patients when they come to the OP, and you counsel them and you send them. So you have to tell them to come for a follow-up, so that you can track the patient's progress through these periodic follow-ups and try to adjust their dietary plans in case they are not improving. For example, a weight loss program, you will have to have a constant follow-up with the patient, so that they can try to reduce weight comfortably. Okay. Otherwise, if it is cumbersome or they're not according to their routine, then they will not follow for a longer time. So it will be a failure for them. So you have to give them a dietary plan that will be able to, that the patient will be able to follow regularly. And you have to tell them, give some ideas as to maintain a food diary, or you can give them some tips to maybe some apps which will help them to motivate, and tell them to come and meet you, or if it is difficult for them to meet you, or they're in a different city, you can tell them to send the details in a WhatsApp. So that will help them to actually connect with you in a better way. So providing ongoing support and motivation to achieve their dietary goals will help them in a long run. And the next is collaboration with the healthcare team. So it is not one person working in a hospital separately. You can provide a wonderful work. No, you have to work with the team so that you can provide the best for your patients. So you have to, as Divya was detailing on how to connect with the different healthcare team members, like the doctors, nurses, or other professionals. She also said that you will have to connect with the speech pathologist. So there might be a neurological problem patient, like a CVA patient in the OPD who has come for a review, who has difficulty in swallowing. So the speech pathologist would have referred the patient to you. So you need to again discuss with the team and try to provide your expertise to the patient as a whole. It should be a holistic care plan for the patient. And specialized diet planning, there are a few areas where you might require out of the hospital. A pregnant woman or children might require a healthy diet plan. And nowadays there are several senior citizen homes, or not only homes, there are living together places where many elderly people are staying. So you might have to educate them, or educate the people who are preparing food for these elderly people. So you have to move out from your clinical setup, and maybe you have to meet those patients there also. And some of them might be healthy, some of them might be bedridden. So accordingly, you will have to develop and manage dietary plans for these type of patients also. And apart from that, there are certain rehab centers who might also ask for a help from the dietitian. Any rehabilitation centers, pulmonary rehabilitation is there, neurological problems, patients with neurological problems also need help from the dietitian. So after discharge, the role of a dietitian does not end in the hospital. It has to continue till they come back to the hospital for a review, or sometimes it might, your help or your expertise might be required for a year also. There might be few patients on a rice tube who might require your opinion and expertise even after 1 month or 2 months. Or sometimes you might have to provide them a modified diet because they are not improving in their weight, especially the patients who are post-surgical patients or any oncological patients. They have to meet the dietitian whenever they come to the OPD, or they can come and meet you even if they're not going to meet the doctors. At least once in a month or once in 2 months, you should connect with them so that their nutritional status improves. And research and continuing education, it does not end with counseling alone, but small details can be noted down in your OPD, because you will be doing nutritional and detailed nutritional assessment. You can collect data and you can have an evidence-based practice based on the latest research from across the globe. And you can also do small research projects and improve the quality from your department also. Next. So what are the steps involved? I think I have detailed in the previous slide itself. You have to do the detailed patient assessment, gather information on medical history, lifestyle, food habits, socioeconomic status, cultural preferences, etc., and evaluate the anthropometric measurements. Nowadays, I think all the OPDs, they do the BMI, they check the height and weight, and we do the BMI calculation. And laboratory data, you can collect it, and the clinical findings can be done with all these data. And nowadays, few hospitals have the body composition analysis machine also. So with that also, you'll be able to collect the details and explain to the patient in a better way. So for that, we'll have to be equipped. We have to keep learning more. So identifying the nutritional issues. So based on the assessment, you'll be able to identify the nutrition deficiencies or excess or undernutrition. And it is very important that when you sit with a patient and educate them, before doing the education, you will have to tell them to set the goals. So when you explain that this is the problem, this is the deficiency, this is your value, this is the normal value, so we have to increase. So what do you think you can do? How do you think you will be able to improve your, for example, in case of anemia, how will you be able to improve your iron status, hemoglobin? Like that, you will have to ask them and then set a goal. For example, in case of weight loss also, we have to get the confirmation from the patient so that it is they're able to follow. And education and counseling, it has to be simple, understandable by the patient, and whatever you explain, it has to be with the portion sizes. You will have to show the portion sizes, you have to give a detailed menu plan, and you have to clear
Please
their
mute just 1 minute, Kavita. Please mute yourselves. All of you, other than the speaker, please all of you mute yourselves.
And meal planning has to be personalized, and it has to be tailor-made to the patient's medical condition as well as his preferences and his lifestyle. As I said, what is his routine, we'll have to find out, and based on that, you'll have to plan accordingly. And it has to be definitely budget-friendly, easily accessible in his area, and the seasonal foods have to be included. And definitely it needs a behavioral change in the patient. So motivational interviewing and techniques to involve the patient in the dialogue is very important. And in case there is any barrier, sometimes the patient will say, I will not be able to do this because I don't have access, or nobody in my family is supporting me. So you will have to find out the barrier that the patient has and try to rectify it, or help him, or bring him with practical solutions. And after all these things, your menu plan, education, everything, unless you follow the patient and monitor the patient, it will not be successful. So we have to have a regular schedule for follow-up to assess the progress of whatever you have advised, and try to change any, in case there is any challenges, you'll have to resolve that. and adjust the menu plan as and when it is needed. And sometimes you will have to reinforce the positive changes and provide encouragement to these patients to follow your diet plan. Next. And not only referrals from healthcare professionals, you also might have to send your patients to other healthcare practitioners for a referral. So when the scope of the patient needs exceeds nutritional counseling, you have a patient, you identify his problem, nutritional problem, and you advise them. And after a follow-up also, if you see that the patient is not improving, then you might have to refer the patient to a doctor or wherever he has to be referred. So the dietitian ensures that there is a continuity of care by directing the patient to the appropriate healthcare provider. Next slide, please. So in case you see that the symptoms or suspected conditions, like there is constant fatigue, even though you advise them to have regular, small, frequent meals and you give them a high calorie, high protein diet, all those is there, but the patient complains of fatigue, tiredness, and unaddressed health complaint, then you will have to refer the patient to a physician. Okay, or sometimes their thyroid levels are not under control or their diabetes is not under control, even with the perfect diet plan and exercise, then you will have to please refer the patient to an endocrinologist. So depending on the condition and the symptom, you will have to refer the patient. And sometimes whatever you tell them, they will not be able to follow your diet. There might be some psychological disturbances or that is hindering their intake. So you will have to, for a mental health support, you will have to refer them to a psychologist or a psychiatrist for eating disorders like anorexia, bulimia and all, or sometimes there'll be emotional eating. I'm stressed, so I eat more, or I don't eat. So all these things can be detrimental because they might eat more and it will end up in obesity, or they might eat less and they will end up in deficiency. So you will have to identify these and refer them. Sometimes there might be a referral to a therapist also, because certain conditions will need a physiotherapist, help of the physiotherapist, especially neurological patients or a patient, anorexic patient or a patient, cachexic patient. They will, whatever high protein diet you give and high calorie, if proper exercise is not done, exercise plans have to be done for their muscle development. So no, it is not sufficient. I give a high protein diet, I have advised a high protein diet, the patient is having a high protein diet. That is not sufficient unless you do a proper physiotherapy exercises. You will not be able to build muscles for these patients, especially the neurological patients. So physical rehabilitation or exercise plans have to be tailored based on their health conditions. And sometimes certain patients for weight reduction, if they approach you, and sometimes the diet might not be sufficient, diet changes might not be sufficient, they might require a structured exercise program for weight management. So you will have to refer these patients to a physiotherapist or a fitness expert. And some conditions like IBS or celiac disease, chronic constipation might require medical intervention, and you will have to refer these patients to a gastroenterologist. When you collect the details, the history, if they come out with these problems, with these symptoms, you will have to refer them. And sometimes patients will have chewing, elderly patients will have chewing or swallowing difficulties, oral ulcers. So definitely they might require some help from the dentist. You please refer them to them, these dentists. Next slide, please. And speech language pathologists help us in areas where the patient has swallowing difficulties. So when there is swallowing difficulty, definitely there will be decreased intake and these patients will be undernourished. So you will have to refer them to a speech pathologist. And when you think that the patients having chronic disease, kidney disease, even with the diet, they are progressing, which means their lab values are erratic, increasing, then you please send them to the nephrologist. And cardiologist, if you think they need some specialized treatment apart from the diet and exercise, then you will have to refer them to a cardiologist. And certain conditions like where you cannot control their patient's weight with the diet and physiotherapy, exercises or fitness, then you will have to refer them to a bariatric surgeon. Gastrointestinal surgery or other interventions might be required depending on the case. Like they have some GI disturbances and they might need a surgeon's opinion also. And definitely if you see cancer patients, oncology patients with nutritional concerns related to their treatment, you have to talk to the medical oncologist or the radiation oncologist and check whether the treatment procedure is affecting their food intake, and try to have a talk with the oncologist and then decide on the nutrition support, and also find out if certain drugs are affecting the nutrition intake and have a dialogue with them. Next, pediatricians, if there is a growth concern or malnutrition, if you find any specific medical conditions, you please refer the children to the pediatrician. And pregnant women or with those hormonal imbalances which affect the nutrition, you please refer them to the gynecologist or the obstetricians. Sometimes it is not, maybe you do the diet counseling and other things and the patient is not able to follow because of financial constraints, where they are not able to access the right nutrition. Then you can try to find a social worker and try to get some financial support from others so that they can improve their nutritional status, especially the oncology patients and all, they might need some financial support. So when we direct these patients to the social worker can get the financial help from the other philanthropists or other people, NGOs and all, where they have access to the financial supporters. And public health nutritionists, in case it is the community-based intervention or any food assistance programs, then you will have to refer them there, so that everything cannot be corrected by the nutritionist alone or a clinical dietitian alone. Sometimes we'll have to have a hand with the other healthcare professionals for the better improvement of these patients. Next slide. Thank you. So it is just not diet counseling alone. It should be a holistic approach where you will have to discuss with the other healthcare professionals in case you need to ask about the patient's progress or the treatment to the doctor, or in case they have to be referred to the other professionals, you will have to do that. And in a clinical OPD, the assessment is very important. Before assessment, you will not be able to give a detailed diet counseling. So assessment is important along with the proper diet counseling, and motivation is the next part. And the last one is follow-up. So follow-up is mandatory for a good outcome. Thank you.
Thank you, Kavita. You explained beautifully all the aspects of OPD and counseling. Thank you for that extensive talk. So I think it is very clear to everybody that counseling in OPD is actually an art. You have to gain the confidence of the patient if you want the patient to come back to you. Because in India, in most places, you'll find that the people, they are not willing to go to a dietetics OPD. They typically would like to ask their doctors, Dr. Saab, what will we eat? Can the others please mute, please? Okay. So basically, the people, they do not want to come to the dietetics OPDs because they probably do not have a concept about the diet counseling part, and probably also because they do not give importance to nutrition as a therapy. So the idea is that they will go to the doctor, they will ask the doctor what to eat, what not to eat. The doctors are way too busy to talk to them. So the thing goes unnoticed and it goes ignored. So if we as clinical dietitians, if we need to draw people to the outpatient department, and if we need to make them aware about the importance of nutrition, then we have to learn the art of diet counseling. And as Kavita has beautifully spoken, she has explained all the aspects. Every patient is different. You need to talk to the patient, find out what the problems are, and give a proper diet plan, proper advice which the patient can follow. So we need to spend time with the patient. And in order to do this, for all the aspiring dietitians who want to practice, you need to be trained how to do this. It's not that just you pass out of your college and you just sit with a doctor and you call yourself a practicing dietitian and you start dealing with patients, because there are many aspects you need to learn. How to talk to the patient, what are open-ended questions, what are close-ended questions, what is it that the patient likes to hear from the dietitian. They should not perceive you as somebody who is just there to tell you don't eat tasty food. We have to explain to them exactly what we are asking them to eat and why we are asking them to eat. So it's about nutritional awareness and nutritional education. So for doing this, we also need to train the people who are doing it. So thank you, Kavita. If there are any questions, we can take it later. I now come to the last lecture by Dr. Edwina Raj. She will be talking to you about the clinical research in the field of clinical dietetics. Nowadays, we do have a lot of research opportunities in the field of dietetics. You can publish your articles in many well-to-do journals across the globe, but then there are also other places where we find that the dietitians are slipping because they're not aware which are the proper journals where to publish, which are the ones to be ignored, which are actually having some basis, what research is to be done and how it is to be done. So in order to guide us in the aspects of research in the field of clinical nutrition and dietetics, we have Edwina Raj from Aster, Bangalore. She will be talking to you on research in the field of clinical dietetics. Welcome, Edwina.
Thank you, ma'am. Thank you for your kind introduction. At the outset, I would like to thank Sangamitra ma'am, Kaho, and HSSC for giving me this opportunity to join here in this platform. So I'm going to talk about how we can integrate clinical nutrition research in our hospitals. Basically, what we understand is when it comes to clinical nutrition research, there it is not that we have not been involved in research. So most of the practicing clinical dietitians, they have been conducting research in their practice, but only thing is some of us may not be able to get through the right publication or quality research. So this is something that we will have to understand. It is need of the hour that we have to continue publishing research papers. Why? Because clinical nutrition as such, it has a potential role in preventing diseases and treating as well as managing health conditions. So we need to emphasize on integrating nutrition science in our clinical setting, and also because we have to understand how patient outcomes that we all aim to achieve the clinical outcome, how we can do it through evidence-based practices. Next slide, please. So looking at, so some of us have this understanding that research is not being focused in our country, but of late we have seen India is world's fourth largest producer of research output. So we have seen many other fields who have been contributing to research in our country, but we do not come across much of clinical based research that has been contributed. So government is actually funding for the research studies. Only thing is, we as clinical dietitians, we will have to gear up and start working on the research aspect of clinical nutrition. Next slide, please. So if you see which are the key areas where we can focus and how we can do clinical nutrition research, one is we do nutrition assessment. My co-speakers have highlighted about assessments previously, how we do, how important is nutrition assessment in OPD, and what is the role of a clinical dietitian in hospital setting, how she needs to collaborate with other teams. So we have been conducting all this, whether it is for inpatient or whether it is for outpatient. So most of the research that have been conducted in Western countries, we have been incorporating those guidelines. So we should also come up with standardized assessment tools for our Indian setting. Basically, we need to come up with those, and this is one platform where Kaho has given us the opportunity. We can look forward in conducting more research studies in this field, basically. And understanding about anthropometric data, it is not just about height, weight, what we record, BMI. We have also, in our setting, we also have this bioelectrical impedance, body composition, which checks patients' fat percentage, muscle. So we can also look at the Asian cutoffs for these parameters, not just going by the Western cutoff range. And biochemical history, we record regularly the biochemical data. When we are on rounds, we check the blood glucose levels, electrolytes. These are all available with us. It's all been documented. So we need to start deep diving into these parameters and how we can capture this, analyze this, and then arrive at a conclusion. So diet history, nowadays we have software. We record patients' history, that should be prioritized before we do any intervention. Assessing patient is quite important. So we have been doing this, taking patients' history. It needs to be documented, and most importantly, we have softwares available. It could be NSR, DietCal. So many softwares are there wherein we can capture and understand the intake of the patient in terms of macronutrient intake, calories, how much patient has been consuming in terms of calories, protein, fat, carbs, and so on. And thereby doing nutrition focused physical examination, as the previous speaker, Ms. Suzanne, also has emphasized on this. It's not about earlier times we're not going assessing patients closely, but now it is not like touch me not dietitian. Rather, we should touch patients, feel the patients, understand the physical signs. The physical examination should be prioritized. We should do the functional assessment through hand grip dynamometer and so on. So all these assessments can be useful for us. We have also done a neck circumference study, which is an easy tool to assess patients, to categorize them whether they are obese or overweight or whatever. So like this, probably we can look at more comprehensive assessments according to the guidelines and start incorporating them in our setting, and then looking at how we can do research. And thereby, we have been involved in doing dietary intervention. So we can see the outcome in patients, and then this can also be one area of research. Nutrition assessment tools, there are many softwares available. Probably in further talks, we will be able to tell you how we can look at the various softwares that are available, and it is easy for us to conduct research. And AI coming in, so these are it's very simple for us to do it. Only thing is we will have to keep aside at least an hour of our daily time so that we can contribute something in the research field. So there could be some opportunities even in product development. There are many FMCG companies wherein they have products. For example, they have millet mixes available, but how it can be used in clinical setting for various disease condition, and what is the outcome of patient taking this product, so that this can be a value add to the product itself, for the person who's come up with this product. And also, we can come up with more research studies in our country. We have plethora of herbal products available. There are so many ingredients in India that we have indigenously. We have been using it. So we can think of collaborating with these companies and conducting research studies. Otherwise, even disease prevention. So in India, we have come across India is number one in the world for diabetes or lifestyle diseases. So as clinical dietitians, we can also collaborate with doctors and then understand how we can do research in terms of preventing lifestyle diseases, diabetes, heart disease, cancer, and so on, and even when it comes to understanding certain hormone related issues in women, how to prevent that, so we can involve ourselves and collaborate with other field other clinicians and come up with a better research work. So, next slide, please. And even understanding the nutrient physiology, for example, be it magnesium or omega-3, how we can apply this in the various clinical aspect. So moving on to the methodologies involved in clinical nutrition research. So we understand that research is important. There are various types of research, but how we can apply that when in our clinical nutrition and dietetics field. One is experimental based research, where this is gold standard basically, where it involves randomized control trials, where if you want to try any product, so, or if you would want to do any study on any protein supplement and so on, this actually this has a better value. But the only challenge here is we need ethical committee approval. We need better understanding about the ingredient what we are using, and this might be little difficult in clinical setting in most of the times, but if you get approvals for this, then it's great that you can publish a good paper out of this. So such research studies are mostly valued, in fact. Otherwise, observational studies is something that is easy for us to conduct at our clinical setting, which involves cross-sectional studies. This cross-sectional study is simple. Why clinical nutrition studies fail at times is because we need follow-ups. So clinical nutrition, if we have to do any diet intervention, we need patients to comply to that at least for a duration of 2 months or minimum of 3 months. There would be we would anticipate mostly dropouts. Many would not continue the diet intervention and they wouldn't come back to us. So that's the reason cross-sectional study would be more helpful in dietetics field, where this is a single point of time where you conduct research. You track the data or prospective data, whatever is available or whatever you can record. One time you will be recording the data and you will be able to analyze the data and come up derive with conclusion. So for example, any nutrition assessment that we have already been doing, so that data we can analyze, or we can also understand if the patients are taking any supplements. So that data we can assess. So this is something that is simple and easy for all of us to follow in our clinical setup. And cohort studies, wherein we need participants to come back for follow-up. These studies are more useful for arriving at certain evidence-based conclusions. Basically, this research study has more value. So this would be difficult because you need patients, you need to do frequent follow-ups, you need to have proper manpower to conduct this kind of research, wherein you'll have to keep following up, understanding the intervention, and taking the diet recall of patients. So this would be little difficult, but if you have enough resources, you can conduct this study. And then systematic reviews and meta-analysis. This is something that's simple for all of us to do it in our practice, wherein you summarize the existing research data, whatever research has been conducted already, we start analyzing it and coming up with a review paper, which is much easier for all of us to do it in our day-to-day practice. Only thing is we will have to keep aside an hour of our daily time to carry out this research. So this is something which will help us to understand the existing guidelines. For example, if there is any cancer related guidelines available, what is the validated tool that has been used for cancer patients when it comes to assessment, and what are the intervention, what the guidelines talks about the intervention in terms of cancer patients. For like this, we can summarize and then publish our paper based on this. So qualitative research and then epidemiological research or case study based, case controlled, these are all questionnaire based, interview based. We need to do in-depth analysis. So this is also possible if you have enough time and interest to do it. Case study based is something that's very useful. Why? Because we do have interventions going on. We have trainees available, interns, so we can give them a small case study and publish these case study papers. There are many journals who accept case study based studies also. Next slide, please. Mostly case study based published papers will give you a kind of satisfaction, and you ultimately feel that you have done a good job in patient's clinical outcome. So this would be more useful for our Indian setting also, because we need more understanding in terms of case studies that we carry out. Next slide, please. Yeah. So what are the advantages of conducting research in clinical nutrition is because in our day-to-day practice, we see patients and we do the intervention, but in research work, we do an in-depth analysis. We come out with decision making. We understand the nuances of different issues, different disease condition. We dive into the disease condition, and that's when we work towards a better clinical outcome. So we will also address the gaps wherever needed, and we will improve our knowledge. Basically, we will develop a critical thinking, and we can also position ourselves. We can showcase our work, and we would be more visible in terms of other clinicians with whom we interact. We can collaborate with doctors. This will in turn increase referrals to your clinical practice. Basically, when you collaborate with different team members, it could be physiotherapists or speech language therapists or psychologists, or it can be clinicians, doctors. If you collaborate with them and come up with the research paper, there would be better rapport maintained with the other doctors, and you would get more referrals also, and you would also build trust with each other in terms of they can rely on you, they can send their patients, they would you would increase your referrals basically. And this would be possible. You need not have to conduct an elaborate research. It is possible through simple online surveys also. So next slide, please. So how do we incorporate it, and how do we do it in our day-to-day practice? Only thing is, most of the written formats would be difficult to analyze, to assess that data. So it's better that we prioritize and document everything, whatever we see in terms of nutrition care plan. It needs to be documented in the system. We have hospital information system. All of us, most of us would be having. So digital assessments, digital case sheets would be easy for us to conduct research rather than paper-based prescriptions. That would be difficult. So it's better that we scan most of it in case if we have any paper-based, and save it in our system, so that it'll be useful for our future research. And we can analyze the data in case if we have already analyzed the data, we have understood that there is a better outcome in certain cases, then we can go back, take the approvals, and publish this paper as well. So a review article is something that's easy for all of us, and I insist all the practicing dietitians to start writing a review article. Draft a protocol and keep it ready. Keep the abstract papers ready, handy, so that you can immediately publish it. There are many conferences who would be insisting that you can showcase your abstract also. So that is an easy way to do it, and you can also collaborate with institutions. So as a practicing clinical dietitians, you can also collaborate with certain universities, institutions, so that you can take help from them. They can also send their students, and they can work on certain research topics. You need not have to do all the research work. Rather, you can get help from them, and you can be a co-author also in their publication, rather than you doing it by yourself, which would be time consuming. So in this way, get yourself registered as a research guide for most of the PG students. So that is another way where you can do it. Yeah, next slide, please. So how do we evaluate? There are many research papers available. We cannot just go to Google search and get the research paper and start looking at it, start reading and start practicing, translating it into our regular practice. Rather, we should always pick up the Google Scholar. Through Google Scholar, it is more reliable for us to get the right research papers, because most of it are predator journals. There are fake journals available wherein you may end up reading wrong information, and that we will, whatever paper we pick up, we will have to see whether it is being published in a proper journal, Scopus indexed, a journal with high impact factor. Any impact factor more than 3 would be more reliable, and we should see whether it has been peer reviewed. It has, it has got the right type of information. And another important thing is whether it has been conducted, the research has been conducted on animals or humans, or it is a review paper. Or even we can also see if the study has been conducted for a long duration or a short duration, with how much sample size. Some study, for example, they would have done it just in a very small sample size, like 25, 30. For example, they would have used some product on just 25 patients, and they would arrive at a conclusion that this is the best product. So these are some of the things that we will have to remember when we look at any research paper. So look at always publishing it in a good journal, because there are many fake journals available. You would be wasting your money. Next slide, please. So some of the challenges that we come across would be, because nutritional intervention, nutritional based studies, they are all, most of it is long-term study. So we would be, sometimes it would be challenging. Many dropouts would be there. People will not be able to follow. And in India, we have different cultural backgrounds. So it may be difficult for them to follow up and come back, or they wouldn't be able to continue. Or some of them would be on medicine, some of them would be taking alcohol, or some of them would be smoking. All these are confounding factors that would impact your research. So these are some of the challenges that you come across. Or it would be difficult for you in a clinical setting to get approvals also. At times, funding would be a challenge. So for all this, we need to start working on, maybe before this, I have just explained the simple ways, just a review article or just a case study based, simple based studies we can start and begin with, so that our research work can be showcased and we can start looking at evidence-based practices, basically. Next slide. So next slide, please. In summary, next slide, please. I would want to say that clinical nutrition field is rapidly evolving. So we need to pitch in, gear up, and start working on research papers so that we can see better outcome in patients. So we need more of innovative technologies, tools, so that our work becomes more simple as dietitians also. So I would encourage most of you to collaborate with different institutes and start coming up with more clinical nutrition research papers. Thank you for your patient listening.
Thank you, Edwina, for that lovely talk. So in hindsight, it is very important for us to start some clinical research, because in India, there's a dearth of Indian guidelines. And unless we actually publish the work that we are doing, we are not able to set standards for the Indian population. So without much delay, I would like to ask Dr. Megha to please take over in case there are any questions. Dr. Megha?
Yes, Sangamitra ma'am. That was a very insightful session, ma'am. Thank you so much for this great panel discussion. Just a It was a great session. Thank you so much, ma'am. If we have any questions in the chat box, then we can take them up. I don't think so. We have any questions. That was well-informed session. Thank you so much for the same. I have only one question from my end to ask. Uh, what are the contributors of a dietitian in the field of clinical research? And what is their role as in the multidisciplinary clinical team? So could we enlighten something on this question? So that would be really helpful.
Okay, so Edwina, I think you can speak on the clinical research part. Edwina?
Yes, ma'am. Can you please come again? If you can repeat the question.
So my question was, what are the contributions of a clinical dietitian in the field of clinical research? How the clinical dietitian can contribute in the field of clinical research?
Yeah. So, as I've already elaborated about our generally we practice everything when it comes to nutrition assessment. We take our daily rounds. So we document everything. Only thing is we will have to go back and start analyzing the data. And start understanding wherein the gaps are involved in our practice, and we can also come up with better publications. We can also look at many journals. So in case if we are involved in this practice, regular practice of looking back to our data and then analyzing it and then deriving at conclusions, that is another way where we can start, as ma'am also mentioned, that we can start coming up with guidelines, the standard operating protocols for our Indian setting. This could be, helping most of the practicing dietitians so that they can follow an evidence-based practice, basically. Thank you so much.
Thank you so much, Ms. Edwina.
Yeah, the next question was, as a part of the multidisciplinary team, yeah, I think Dr. Divya has already mentioned, basically we cannot work in isolation. So we need to work as a team because that is a more holistic. So typically when a dietitian is working in the ward, she needs to know what kind of exercise the patient has been prescribed. So accordingly, she can plan her proteins, the timing, the delivery. So she needs to work it out with the physiotherapist. The doctor has to discuss his plans. What is his plan for the patient? How he wishes to treat the patient. Based on those lines, we can also think about giving nutrition. And he also needs to know what kind of nutrition the dietitian is giving as a part of his wholesome therapy. Similarly, the nurse also needs to interact with the dietitian because it is she who is there at the patient's bedside, and she can actually revert on how much food the patient has actually taken, what are the problems, because it's not sufficient if you just give a fancy diet chart and it's not implemented. So overall, if we see that unless we work in a team, it's very, very difficult for us to give a wholesome, holistic care to the patient.
Thank you so much, ma'am. Thank you so much. Thank you very much to all the esteemed panelists for this insightful session. I hope audience must have received a good insights, and the dietitians in the audience especially could now perform in a better manner in their field of practice. So it was really insightful. I personally enjoyed the session very much. Thank you so much. We would look forward to have another round of session with this forum very soon. Thank you so much. Namaste.
Thank you. Thank you.
Thank you. Thank you. Thank you for the opportunity.